Oprah style because I have nothing better to do this morning. And I have no slides except for a couple of patient stories that we'll go ahead and get up here in a second. Actually, when I saw what Kyra and Dr. Decker talked about for this presentation was a little bit different than what I was expecting when she asked me to recommend someone for the talk. I thought she was going to talk. Dr. Decker is the head of our what's called our complex care program at Children's, and so they are the quarterbacks for kids who have multiple medical needs regardless of their diagnosis. And so if you're on a home vent and you have a G tube and you need a brain stimulator for seizures. These are the kids that they take care of. And we use their services a lot, actually not so much for this, or for fatty acid oxidation families, thank goodness, but for more some of our other disorders. And so I was thinking about the original title, what I thought was the direction I thought it was going to go, and it is certainly important to have a quarterback for yourself or your kids, and that quarterback should always be the center of your healthcare team. Now I know you all love your fatty acid oxidation doctors, but they can't be your quarterback. They might be the coach. They can teach the quarterback what to do, but they're not. They're usually at a distance from you. They're not the person that's closest to you in care. That's your PCP usually. So I always try to work with PCPs and say, look, you know 95% of the things that you need to do. You know how to treat an ear infection. You know how to treat reflux. I mean, whatever. You got a pneumonia. They're going to take care of that. Not your metabolic doctor. Not your fatty acid oxidation doctor. And so that's the quarterback. Now. In this case, Kyra and Dr. Decker kind of, and we can talk about that if you want, but they kind of turned it around and made the issue slightly different. Just because you have a fatty acid oxidation disorder doesn't mean you can't have something else. You can have VLCAD deficiency, walk out the door and be hit by a bus. It doesn't mean the bus hit you because of VLCAD deficiency. But now somebody needs to take care of making sure that you're getting the right care, and in the context of your fatty acid oxidation disorder. It is a little bit more difficult when it's not so obvious. What if it's not a bus that just hit you? What if it's some other medical condition that anybody in the general population can get, and now you have it on top of your fatty acid oxidation? Let's make it even more complicated. What if those symptoms can look a little bit like what your fatty acid oxidation symptoms look like? So let's start with the first video, you saw these slides yesterday. You can keep going. And we're going to hear the story of Margot, who has 2 children with MCAD deficiency. So go ahead and start that, please. Hope that works. Oops.
MCAD 985A to G, and they have had very different experiences with their MCAD. My youngest daughter has only been hospitalized twice, and she just doesn't seem to be affected by it at all. Whereas my oldest daughter has had a really rocky time. She was hospitalized a lot as a kid, and she's always just become ill very easily. And what I'm talking about is like if she overdoes it at all with activity, or if she is too hot, or she's too cold, or she has a virus coming on, or anything like that, she'll get just ashy or grayish green in her skin, dark bags under her eyes. She gets very nauseated and dizzy, strong headaches. And when this happens, or when this happened, I should say, which it was pretty frequently, like maybe twice a month, what I would do is give her a Zofran and an Advil and put her to sleep in a dark room, even if it was like the middle of the day. And then feed her, in her sleep every couple of hours, and when she would wake up in the morning, she'd be fine. But it was a pretty big impediment to her normal life, and pretty uncomfortable for her, frankly. And if I didn't do this protocol with the Zofran and the Advil, she would start throwing up, and it would sometimes be a long time before she could kind of stop throwing up. Maybe a day of being just really nauseated and sick in bed, just kind of feeling really awful. And obviously, throwing up is a bad thing if you have MCAD. So, we always took this to be a symptom of the MCAD. Like, boy, her blood sugar is all over the place. She's really acting sick because of her MCAD. And her geneticist, at one appointment when I was kind of complaining about how hard MCAD was for her, he goes, "That doesn't sound like MCAD." And I was like, really? Because, that is how we had described, or heard described, what, the symptoms of insufficient feeding in an MCAD patient looked like. And so I ended up taking her to an endocrinologist because I wanted to see if her blood sugar was unstable, even though we were feeding her every couple of hours. We took a blood sugar monitor home, and we found that it was not falling too far below the range, if at all. Even after 12 hours of sleep, her blood sugar was still in the 80s, so we were fine there. And the endocrinologist said, when I described all the symptoms she was experiencing, he said, "Well, sounds like MCAD." And I was like, and that's more or less what her primary care physician had said as well. So lots of blood tests, food sensitivity tests, and all sorts of stuff like that, and really getting nowhere. And then I took her to a gastroenterologist, and he did more blood tests and spent some time talking with her and listening to all the issues. And he was very familiar with fatty acid oxidation disorders already, so I didn't have to talk to him or explain them to him. And he seemed very knowledgeable about them, I'll say that. And he diagnosed her with either cyclic vomiting syndrome or intestinal migraines. He said that they have very similar clinical presentation. And when we started treating her for that, the constant vomiting attacks stopped. So it took us about 6 years to get to a diagnosis. I'm trying to make it brief for you guys, but it was a long journey of frustration because everyone just said, "It sounds like MCAD, it sounds like she's not eating enough, or you need to start giving her Gatorade sooner, or you need to restrict her activity." But when we started treating the cyclic vomiting syndrome, the episodes of extreme nausea and vomiting and just feelings of unwellness stopped, and she's been able to do a lot more activity, and it's only occurred once or twice in the past 18 months. So it's been a huge change for her, for our quality of life as a family.
All right, so frequent episodes of something that is being put off as part of her fatty acid oxidation defect. Let me just start by asking: have any of you been in that situation? Have any of you been in a situation where you were just not able to control yours or your child's fatty acid oxidation disorder for some reason over a course of time, and no matter what your metabolic doctor did, it just wasn't working?
Yeah, just especially in the toddler years, just continuous vomiting. and no one could get a handle on why it was happening. And sometimes like 12 times a day.
And did they ever find anything else?
No, so they suggested the abdominal migraine as well, and they suggested a diet low in tyramine, and that seemed to help. But I also wonder if just growing older helped.
So my daughter has had continued issues with nausea and constipation and also with chronic pain, and we had worked on trying to find out what was wrong, went to a bunch of doctors. She ended up getting diagnosed with IBS, with the constipation being what was causing the nausea because she was so backed up. But the chronic pain was really causing an issue because every time she would have all that muscle pain, they would think she was having a rhabdo episode. So she would go to the doctors and get labs drawn. CK was always fine. And it took a couple years, I think, to finally, it was to the point where it's like, she might need palliative or something because just her quality of life is garbage. She's a teenager, she can't function, she's in pain all the time. So we sent her to the pain clinic at Boston Children's, and they were finally able to do some treatment to help her kind of tolerate that pain because it really didn't seem like it was the CPT2 deficiency that was causing it.
There's a really important point in there, and that is there are primary symptoms of your fatty acid oxidation disorder, then there are secondary symptoms. And the secondary symptoms can be learned responses of your body to a repeated stimulus. If every time you have a rhabdo episode, you have a ton of pain, then you learn that pain is part of your disease. And so anything that causes you pain automatically starts you're thinking about fatty acid oxidation, but the other way around happens as well. You start with a very early episode that you're otherwise able to turn it around by doing the things that you heard about. You pull your go bag out and start eating. But now all of a sudden that's not working anymore because your body has just learned those signals that turn you in that say I'm now expecting pain, and so it happens. And interrupting that cycle becomes really important. And so now we got two things that we're worried about here. One are the secondary, your body's learned response to what happens when it starts having a decompensation, and the possibility that you might have a second disease. We've really become alert to this idea of two diseases in genetics very recently because over the last 10 years we've moved from checking just for the things we think about to checking everything all at once. It's a technique called exome sequencing, and in the early days of genetic testing, molecular testing, you would work a patient up and you'd say, I think you have symptom or syndrome X because of this particular set of symptoms. But this is not quite right and that's not quite right. But we know diseases are variable, so we would sequence the gene for that disorder in those patients, and sure enough, they'd have it. And we started broadening the definition of these disorders. Well, now we know it started with one symptom, but now we can have 3 symptoms on this side, 3 symptoms on that side. As the technology changed, it became easier and cheaper to just sequence all your genes at once. Rather than one at a time, because sometimes you're wrong, or sometimes it's there's overlaps, and 3 or 4 things can all look the same. And amazingly enough, 5% of our patients who we now make a genetic diagnosis in using that technique have 2 things and not one. What we used to think is variability in one disease was actually the superimposition of a second disease on top of the one that we originally recognized. So it's really important to keep an open mind and have and your physicians have an open mind. Now, Margot said it took her 6 years to get a diagnosis in her daughter. Oh my gosh! That if what I'm doing isn't working, and it's not working over the course of months and months and months, never mind years, it's time for me to rethink what is going on with you, and maybe there's something else we ought to be considering. So in the case of Margot, she was able to find a physician who, first of all, proved that what everybody was assuming was happening didn't, or wasn't happening. She wasn't getting hypoglycemic. And remember that from yesterday's talk and from what Erica said, as you get older, you have more resources to draw on for energy, and it is less and less likely for you to get hypoglycemic, and that's why the rhabdo in the long chain defects becomes more frequent as you get a little bit older. You get more stress on the muscles. You have less tendency to become hypoglycemic. So if there's a symptom that just doesn't make any sense in the context of your fatty acid oxidation disorder, call your quarterback and say, hey, my fatty acid oxidation doc says this might not be due to VLCAT deficiency. What else could it be? My original training out of medical school was in pediatrics, and so I feel much more comfortable when I'm dealing with my pediatric patients and coming up with some of those alternatives. But when you get Alex made the comment about suddenly you're 19 and you're not a kid anymore, in the minds of a pediatrician, maybe that transition occurs a little bit later, but pretty soon you get to a point where my adult patients say, here are my symptoms, and I said, boy, you need to see a doctor. And I'm only partially being facetious because I'm not an internist. I don't play one on TV, and I don't want to be that metabolic physician that's making somebody wait 6 years before we suddenly identify them as having irritable bowel or asthma or whatever it is that's causing their symptoms. Yeah, hang on.
So I have two questions based on what you just shared. Like, one, I'm curious with the way technology is now and how easy it is to do a whole genome, if with our community, like, you would recommend us having our kids do whole genome. And then the second part of the question would be, or if you want to answer that first, I can ask the second.
Let me answer the first one first. So, I would love to advocate for that, and there are two reasons. One is that we still don't know why some individuals with various fatty acid oxidation disorders are more or less severe. Is that possible? Is it possible that is a superimposed second condition, or are there other genes that influence us? We know that there are probably 25,000 genes in our body that affect our growth and our metabolism and are part of our everyday processes. But we know what one of yours does. Whatever disease you have, we know what that gene is doing. But think about height. Height is controlled by probably normal height is probably controlled by about 200 different genes in your body. And if you look at average height, individuals, kids end up to be typically between their parents. So sometimes you have the string being that's way above both. But typically, on average, kids are between their parents. And females are closer to their mother, and males are closer to their father, and that's because things like testosterone and all of gee, I'm going to talk about that later today. Oh, crap! Affect your growth. And so every trait in our body is controlled by multiple genes. And it's not surprising that your your fatty acid oxidation symptoms could be moderated by something else. So I would love to do that study, not because I think everybody's got a second disease, but it would help folks like me better understand why somebody's severe, why somebody is mild, and maybe develop new therapies as part of that. Now, if there is evidence of a second disease, then obviously we would go after that from a genetic standpoint with without hesitation. The problem is, the reality in our medical system is that there's no insurance company around that would pay me to let me do that and pay the bill. You know, you'd end up putting it on your own, or I have to write the grant to do that. I've actually tried to write that grant, and the NIH says, yeah, that's boring. We don't want that. So we're stuck here still saying or thinking about why some individuals are severe and why others are mild. So let me get your second question.
So it kind of piggybacks on that. So then how do you tease out, like as a metabolic clinician, like how do you tease out, okay, when this is not, this exceeds the threshold of being like my area of specialty, or like for the pediatrician, for example, my son one time, he was having issues and so we called the metabolic to him and, oh yes, this is very typical LCHAD, and I was like, I just don't think that it is, and no, and then I called the pediatrician, and she was able to talk to that particular doctor and was just like, but this might be LCHAD, but this isn't his LCHAD. But then how do you make that decision?
Number one is never assume you know everything. And while I have folks coming to me from all over the country asking me about fatty acid oxidation disorders, I still don't assume that I know everything. In fact, I know I don't know everything, and I am perfectly willing to accept that somebody else is likely to know more about the function of the other 24,999 genes that are not a part of your fatty acid oxidation disorder. So it really, first of all, it takes an open mind, you can't be rigid, and you can't be too certain. I always question myself. Somebody asked me last night at the reception, my goodness, when do you sleep? I said, well, sleep is relative, because when I go to bed worrying about you, and that's the only way I know to keep asking questions, my second rule is that the parent is always right. If a parent says to me, something's just not, it doesn't make sense to me. Can we think about it? The answer is always yes. Now, I will try to think about it. If I don't think that it's right, I'll come back to you and say, we're okay. I might even do some extra testing to try to prove to myself that what I think is correct. But then after a while, if it's not making sense, then you have to start thinking about it. So excuse me, a little bit of morning nausea with MCAD is often enough that it wouldn't worry me. But if it's waking up every morning and having vomiting, and this is going on constantly, that's not MCAD deficiency. That's something else. So going, always questioning whether what's happening makes sense in the context of your metabolic disease, and if it's not, then making the transition to thinking about what else could it be. Let's go and see the next video then. You're going to hear about
Hi, my name is Margo, and I have
next one. There you go. KJ has VLCAD deficiency, and then
My name is Tasia Rachitsky.
go ahead. I'll talk
I'm
later.
30 years old with VLCAD. I'm going to talk to you today a little bit about an experience I had last summer. I was on vacation. I was on a trip to New York. I'm from Boston. And I was, walking around doing tourist stuff, and I actually passed out on the street and was rushed to a local emergency room. Obviously, this was a very scary experience, and I've never had really anything like this happen before. I've been to the ER many times, but in this case, I knew it was not VLCAD related. And so trying to work through figuring out what it was and how to deal with it in a New York hospital, which is obviously a different environment for me and one that I was not used to. So I have some tips if you do end up in an emergency room. For me, it ended up being colitis, and I was there in the emergency room overnight and then proceeded to stay there for an additional 6 days. But some tips I have is to always have your information readily available. So when I'm traveling on vacation, wherever I'm going somewhere outside of my normal kind of network of hospitals or doctors, I always have the information for all my specialists, including my metabolic specialist and even like cardiologists and other doctors readily available and on hand. It's important when, talking to other healthcare providers that, in my case, I was reiterating that these were not symptoms of FAOD. A lot of doctors are not familiar with FAODs, and therefore sometimes they try to correlate things that may not be related to it. But again, re-emphasizing that the symptoms that I was having were abnormal, not symptoms of FAOD, and that they needed to be treated as such, but with consideration of my FAOD. Always just stay calm, calm, collected, and kind, but, be firm. You're the patient, you live this, you know what it's like, and kind of what you need to do to maintain your health, and just translate that to your doctor, whether it's your doctor or a doctor in the ER. And don't hesitate to ask questions that are important to your health. Don't feel like you're, questioning the doctor or trying to take away from their expertise. You're really just trying to figure out what's going on and be informed. So obviously in this experience, it turned out really well for me. I was very happy. The hospitalist that I had was very willing to talk directly with my specialist back in Boston. I was very, very sick. I was really unable to do my normal kind of mediation, talking back and forth, or self-advocating at certain points. So he was really talking directly with them and coming up with a plan. He didn't try to pretend like he knew everything about FAODs, or that he would know how to treat somebody. Obviously, this was a unique experience. It was not just colitis, but a person with an FAOD can't fast on top of it. And so he really turned to the specialists, the people who are the experts, to help him build his plan and make sure I was in the hospital and I was safe and was, able to leave, but at a time that wasn't going to be detrimental to my health. So for that, and the way he was able to communicate with me and communicate what they were saying, not only put me in a safe environment and safe health-wise, but also mentally, I was able to be calm, right? I was very worried about the scenario of, not being able to eat or drink anything, given the situation, given my FAOD, and his response really put me at ease. Another suggestion is obviously after an acute case like this, always follow up with your specialist. Talk to them about what happened. If something like this were to happen in the future, is there anything else you can do to be prepared or things that you can tell those ER or other doctors?
I'm ready to give her a PhD in VLCAD deficiency. She's had so much wisdom in that in those 4.5 minutes. Anything resonate with you there? Experiences that you've had. Opportunities that you've had to interact with other healthcare providers in the midst of what she's describing as an acute illness, right? And just like you can get COVID on top of a fatty acid oxidation disorder, you can have inflammatory colitis. Maybe it's even more common. We don't know. You just heard Eric talk about inflammation in fatty acid oxidation disorders. Maybe there's an increased risk, but a lot to learn from what Tasia said. Excuse me. The first thing from my standpoint actually overlapped with the first panel, which was you always you have your records with you. But if you don't have your records with you, you have a way of getting to them quickly. Your protocol letter is 1 page of your medical record. It only gets you through those first few hours in the emergency room. After that, having access to what your disease is important to somebody who is not a metabolic doc and maybe isn't even in the same state or country where you are. I love that Fred can just snap a picture of that QR code and bring up his records. I didn't realize that was a part of Medical Alert. I'll have to take a look at that. Great service, even if it's just to have the last three of your metabolic notes there, right? That says, whenever I write my metabolic note, I say so and so is a 14-year-old with VLCAD deficiency who comes for regular checkup. These are his or her chronic symptoms. Here's a therapy. It's a synopsis of everything that's gone on to that time. It's a pretty interesting option. Some of us in our medical records, our electronic medical record, we can actually access other institutional medical records, but you can't count on that because it's variable, and it depends on whether or not your hospital is participating in it. And there are at least 2 that I know of, which means that there's probably at least 2 more that I don't know of, services that make that happen. So here was a situation where she went to a hospital because of an acute symptom that she was quite sure was not her fatty acid oxidation disorder. And it's a little bit different than what we heard from Margot and her children, or her child, where people were saying, maybe it's your MCAD. In this case, it was clearly different, and an opportunity therefore for the other care providers to first of all say, okay, is this common in VLCAD deficiency? They were willing to talk to her metabolic doc, an important component of team play in this setting, and thus the need for the quarterback. And once it was clear to everybody that this was at least possibly and maybe likely not her fatty acid oxidation disorder manifesting itself, then you just do the same test that you would do for anybody else who shows up in the ER or your as a PCP in your office to check on that particular symptom. So Tasia, I would say she was lucky, but she makes her own luck. She brought her records with her. She advocated strongly for herself, and probably the lucky part was that she ran into a good ER doc who was willing to listen to her. My advice to families who run into that ER doc who won't listen to you is always to just pick up the phone, get your on-call physician on the phone and hand it to the doc. Here's my metabolic physician, because I can't tell you the number of times I've heard somebody say to me, they just wouldn't call you. Yeah, for sure. Well, then you call me. That's the way. That's your advocacy opportunity there is to make sure that the physician is talking to your metabolic doc. I can't guarantee that they'll listen to me any more than they'll listen to you. I've had a number of situations where after the fact I've actually called up the hospital staff of a hospital about a doctor and said, this guy nearly killed one of my patients and you need to know about it. Because they didn't listen to me, there are multiple steps to that. Keep an open mind. Try to help your physicians keep an open mind. Have somebody who is knowledgeable about all parts of your health or your child's health, not just the fatty acid oxidation part of it. Make sure you have the things that you need ready to go to an emergency room if you have to, and always remember you can get appendicitis with VLCAD deficiency just the way you can if you don't have it, and that's so if the doctor is doing an exam and is feeling right lower quadrant pain and saying, oh well, that's your VLCAD deficiency, that's appendicitis until proven otherwise, whether or not you have VLCAD deficiency. That's my story, and I'm sticking to it. Any other questions, comments, experiences you'd like to share?
I just have a quick question. Do you know what Margot's treatment was for the cyclic vomiting?
No. I just saw that video yesterday, I think that her final diagnosis actually ended up being abdominal migraine. And that they treated her for that, and that improved the symptoms. Cyclic vomiting is one of those wastebasket terms that cover a lot of sins, including fatty acid oxidation disorders, if you're not treating them properly. So when I actually do get a lot of referrals for kids with cyclic vomiting, rule out metabolic disease. And sometimes we find them, most of the time we don't. But in her case, I think it ended up being abdominal migraines.
I think one experience that we have had frequently, which is similar to this but a little different, is when Kanan experiences something that is not related to his VLCAD, and that it's an ear infection, a cold, but obviously it is very impactful to his VLCAD. And I think just trying to help doctors understand that there is more to be done, right? Because a lot of times we're coming, they're like, oh, it's an ear infection, he's fine. Go home, do this, do that. Or, oh, it's just this, he'll be all right. We can't treat it, it's just a virus, blah, blah, blah. But they omit the fact that, yeah, it may be an ear infection, but that's going to cause a whole host of other things to go on, which in many cases it does. And probably our longest hospital stay was a case where he had an ear infection, a double ear infection, tons of seizures with high fever. It kept sending us home. We demanded to go back and get tested, and it ended up being like a 10, 12-day stay when it could have been a couple of days a day, listened to maybe taking action quicker, even though it was just a simple ear infection. I don't know if you have advice about how to get them to take action when it is something simple, but it has a whole host of other implications because of the underlying FOAD.
Yeah. So I'm going to start by turning the question or the scenario around just a little bit, and that is when you with any of my metabolic patients, when they are having problems, I want to know about it. But most of the time, I don't want to be the first person to see that individual. because my pediatric training is now 30 plus years behind me, and yeah, I can still look at an ear, and I might even still be able to see the otitis, but I have no idea what the latest antibiotic is, and these days there's even a tendency not to treat the ear infection early on, because at least half of those are viruses and they go away without the antibiotic. So I don't know those things, and I want your pediatrician to see the ear infection. Your job in that setting is to call me and say, got an otitis, and we're okay, just letting you know. Or, after a while you get comfortable with it, I get comfortable with it, and you don't even call me unless things aren't going right. And that's I think the issue here. I have a very, very short fuse to allow my patient or to admit my patients to the hospital. I don't usually view an ER visit as an opportunity to treat and go home. If you or I think the problem is bad enough to come to an emergency room, I almost always, maybe not so much with MCAD, but with the long chain defects, I almost always admit, because the minor illness, as you all know, is the trigger for a major metabolic decompensation. And if I want you in the hospital, even if you're just there overnight, I'd rather be safe than sorry, and I'll talk to the hospital team in the morning. Say, looks like everything's good. I'm really glad that worked out in the patient's favor. We're okay going home now. But that's one area where I tend to be more cautious than not.
So right now, his genetics doctor is like everything, like the entire team. So I was wondering how you can make your pediatrician more knowledgeable. Like, I'm like, he has a runny nose. She's like, see your geneticist. I'm like, his ear hurts, go see your geneticist. Like, she has to deal with everything, even other like vomiting, see your geneticist. Like, she doesn't do anything. I just like.
You may not like my answer. You need a new pediatrician. You can only do one of two things. You can only educate your pediatrician or find a new one. That's not appropriate. If the pediatrician for one of my patients was doing that, I would call them up and I would explain to them why I want them to see the patient. I'm going to get away from the thing here so I don't start feeding back. I will talk to the pediatrician. I'm always happy to do that. Usually the pediatricians the PCPs respond very well to that. They actually are grateful for the specialist taking the time to talk to them. But occasionally you just run into somebody who doesn't want to do it. In today's healthcare system, PCPs are under enormous pressure to get patients in and back out, and they've got 15-minute intervals to do that. Even for sick visits. And so if they think that you're going to take more than those 15 minutes, and that now they're backing up the waiting room, and their satisfaction ratings are going down because people are waiting, now suddenly it's just easier to dump the problem off on somebody else. Find another pediatrician if talking to your metabolic team doesn't work.
Dr. Vockley.
Careful. I want to hear from your doctor.
Hi, my name is Lynn, and I'm Alex's mom. So we've just been through the process over the last year of helping to transition her to college. So we had to put our big girl panties on and step outside of the comfort of her pediatrician, who had been her sole caregiver her whole life. We've been very fortunate. I watched her do something absolutely stunning last summer, but I didn't know what my job was. She was 18 years old. She's legally in charge of herself, and we were talking about going to college, and I had to be confident in what those steps were going to be. So she, because she is her, she contacted a physician's group, and she made an appointment for when we were out there at orientation. And the entire goal was to be set up so that she had a doctor should we need it. I watched her give her entire medical history to a young man, and I watched his face, and he got it. I walked away from that appointment confident that this man, for the moment that he could, he had all the documentation. He immediately scanned her ER letter. He put it in their system so that it would pop up. He scanned her, we called it a cheat sheet that has all of the information that we show up with. And I watched him go through steps that made me, as the mom who had to transfer care to my daughter, feel confident with that process. You have to fast forward, we go to college, and 3 days in, I get the call, we are clearly not okay, and I'm driving 5.5 hours on my way. I remember that this man gave me his card, so I had sent him an email, and I said, hey, just to let you know, I don't know if you've heard, but Alex is not doing well, we're supposed to be getting labs done, I'm on my way. He called me because he knew she had given consent that day for him to talk to me, and then I said, call her. So I watched this process happen. We met a whole group of people because this became a large medical team. We put her in the hospital that day, and I'm thinking, new hospital, I don't have anybody on my team. It's mom go time. Like digging through my bag, and she goes, Mom, isn't that Dr. Gomez? He was waiting for her in the ER, and he had just delivered a baby. He was on the family physician team, and he said, I have talked to them. They know what to do. And I watched my daughter be very grateful for the way he did it. So I don't know how to tell you what the wrong answer is, but I will say there's a way to do it. I think that communicating early, we were very fortunate that we had done the work in June, because in August, we needed them to already know what we needed. So I felt like I hated that we had to do this. For the first time, we had to go to a new doctor, and I had to trust people. And then this amazing resident comes in, and she goes, I saw your videos. I know what to do. And then she comes to Alex later, and she says, and I called your pediatrician, her quarterback. And what more confidence could we have had that we had a group of people willing to learn? And that set the stage for the next year. They changed who her quarterback in Lubbock is. They have a different plan because they found that it was a better plan for her long term. And she spent the last year developing a relationship with the new physician. That the reason she had some bad days in the ER because that woman had just given birth the day before, so their backup plan was not in place. But it's not going to be perfect, but I'm surprised a year later I'm still standing, and my daughter did a great job. But I do think it takes previous work, and I will say I don't know what I would have done if I did not like the gentleman's response, but I watched.
Yes, you do. My mom here.
Have you met Alex Sulzer? I pretty much take my cues from her. But I did tell her I had to be confident in the process too. I had to be confident. She was confident. And I watched him get it. And that was worth a lot. And I will say, don't give up until you are confident that you're building the relationship. They don't know what to do. You will spend a lot of time teaching them. But it was a good example.
I'm just saying, Alex is who you want your kids to grow up to be, okay? We're going to take a break here because you all need to keep eating, right? It's sympathetic for your kids. But we can, I'm happy to go as long as you want.
I just wanted to say I agree with firing your physician. Sometimes that happens. We had that with the pediatrician, but I was curious. I know Emily just launched an ECHO program where doctors that are interested in learning more about fatty acid oxidation, they can kind of come in and talk with other doctors. Do you know of any other programs outside of the ECHO program that helps educate our PCPs about that? I know Dr. Corson also does some education too, so you can send your physicians there for primary care.
It's really hard because those kinds of opportunities are best delivered one-on-one, and it has to start at the other end. One of the nice things that I've seen since Dojoli's been approved is that there are lots more continuing medical education programs out there for PCPs, and a lot of those are being funded by grants from Ultragenics. So they're out there advocating for patients with fatty acid oxidation disorders and trying to provide them with educational opportunities. So if you have a PCP that wants to watch a program, they can. I've done things. I now know about micro learning. 5-minute snippets. People like to 5-minute snippets of learning. I'm like, what? What's that all about? I got a stack full of 60-minute lectures. Don't ask me to talk for 5 minutes. But I did it, and I get feedback that this program is like wildly successful. People like 5-minute snippets. So they're out there, and you can help your PCPs by saying, hey, look, there's lots of CME out there. Actually, everybody needs CME to renew their license. So why not learn about a disease that one of their patients has? Is there another question over here?
I just wanted to know, I don't need the mic, what
Online.
What college does Alex go to?
Texas Tech University. Her dad and I are both alum. She is a 4th generation Texas Tech student.
Texas Tech. Go Tech.